Hello everyone, and let's talk about EMGs. So EMG and nerve conduction velocity tests are a nice way to supplement your practice. I will say that this is strictly an introduction into EMGs and NCV. Do not feel that you can listen to this PowerPoint slide and obviously start conducting EMGs and NCVs. You would have to go through extensive continuing education, but I at least want to introduce you to both of those, and they are a nice way to differ your practice pattern as a physical therapist. Before you go any farther on this PowerPoint presentation on YouTube, I want to make sure that you download all of the slides because all of the slides have YouTube video embedded in them. So what I want you to do is use this as kind of a shell for introductory information, but you're going to notice there's a lot of slides in this presentation that are going to have some embedded video in them or embedded audio in them, and I want to make sure that you go back and you use the video and the audio that's embedded in the slideshow presentation that's on Blackboard to get the full breadth of knowledge of this material. So let's look at, and this is going to take you way back to physiology class. Let's look at a motor unit. So when we're looking at a motor unit, basically what we're looking at is the efferent somatic neuron and all of the muscle fibers it innervates. And this is the basis of EMG study. So take a second, refresh yourself with what a motor unit is, all the pieces and parts of a motor unit, and really have a good understanding of what that entails as we move forward with this material. So this is a needle EMG. It's called a needle EMG because it's an EMG that's performed with the needle. So what we're going to do is we're going to put a needle electrode into a muscle. So this is an invasive procedure. So this is kind of like dry needling, but the needle's electrified. And then what we're going to do is we're going to deliver a little bit of electricity, but the main point is we want to start measuring the bioelectrical activity of a muscle at rest or a contracting muscle. Because if you think about it, if we have a muscle that's supposed to be at rest and it's giving us potentials for a muscle that's active, then we have a problem on our hands. Why do we do an EMG study? So, like I said in the last slide, we want to determine if a muscle is inactive at rest or if it's firing. Because if you think about like a spasmed muscle, that's going to fire when it's at rest. We want to determine if a particular muscle is responding to stimulation. Also, it can be very, very key in looking at things like different diseases. Think about multiple sclerosis. Think about things like myasthenia gravis. So there's some other more complicated diseases that this really is a warranted modality for in terms of diagnosing and in terms of imaging. So I really want you to think about this as another way to perform diagnostic imaging. We're just not getting a picture in the traditional sense. So looking at what the diagnostic value is of an EMG, obviously there's a small list of pathologies here. We've kind of discussed a couple of them before. Myasthenia gravis is one of them. Spinal muscle atrophy is another one. I actually worked with an individual as a volunteer who had spinal muscle atrophy. It was really, really interesting. It was very, very different presentation, but that would be an individual that would need EMGs not only at the onset or the diagnosis phase, because this individual was diagnosed as a child, but also to measure progression and see how he's doing with periodic checkups. Now, take a look at this slide. This is a motor unit potential. So obviously we know that when a motor unit contracts or a muscle contracts, that we have a depolarization and a repolarization that happens. So what we're looking at here in terms of a motor unit potential, that's the sum of the muscle action potential supplied by the anterior horn cell. And the way it works is the muscle fibers discharge in a synchronous format adjacent to the needle electrodes. So right next to the needle, the muscle fibers will discharge an electrical signal, if you will. And then the motor unit potential then has a higher amplitude and longer duration than the action potential because this is produced by a single muscle fiber. Okay, so just make sure you understand those terms as we go forward. In looking at the components of an EMG, what we have is we're going to put the needle into the muscle. Needle's held at about a 45-degree angle towards the origin, and that's the origin of the muscle. And then what we're going to do is we're going to monitor insertional activity. And then what you look for is you look for anything weird, anything sort of like a spontaneous activity or resting activity. You also look for any recruitment of motor unit potentials. Just like with every other treatment we do, before we start sticking needles in people, before we start manipulating spines, before we start doing ultrasounds on folks, we got to go through contraindications and precautions. So honestly, hemophilia is a caution. It's a precaution, not a contraindication. Just be careful. We want to make sure that we're appropriately consulting with referring practitioners. Honestly, the patient has to be very cooperative. If the patient is twitchy, or they won't sit still, or they don't want to do it, or they're going to give you a whole bunch of problems, then we're not going to get a very good test, and we're going to have a problem on our hands. Any patient with a history of a heart attack or any other sort of extreme illness, we want to make sure we're really carefully monitoring them during the test. And then if the patient is going up for a muscle biopsy, or they had a muscle biopsy done and we're still waiting for the results, really should make sure that we're going to do a proactive communication approach, and we want to make sure it's okay that we're going to EMG in muscles. Probably don't want to do it in the muscle that just got biopsied for a very good reason. And then we're going to do a blood draw, honestly, for CPK levels. Make sure that we're okay, and we're honestly make sure we don't give the person a heart attack. And then honestly, there is a risk because we are putting a needle into the body. There's always a risk for pneumothorax. So this is a big point where you want to switch over to the PowerPoint slides so you can listen. And that's going to be the big thing, is you got to have either headphones in or the volume cranked up on your computer, because these are very, very subtle sounds that you're going to hear. Normally what we're going to have when we first put the needle in, it's going to sound like static, or the best way I can describe it, and this is because I am from a different generation, fortunately or unfortunately, depending on how you want to look at it, that I can remember a needle on a record. So if you ever kind of know that sound of needle on a record, that's exactly what this sounds like to me. So now let's get into what's called normal spontaneous activity. So what this is that in a normal muscle at rest, everything should be pretty silent, okay? Except when the tip of the needle is in the vicinity of the neuromuscular junction or the end plate potential, or you may have an end plate spike. Normally what's going to happen is exactly what you're going to hear, and just be aware of how this can be a normal spontaneous activity. The reason being is because, honestly, let's think about it. If you stick a needle in someone, there should be a little bit of a reaction. There should be a little bit of a flinch. And that's exactly what a normal spontaneous activity is essentially a flinch. So looking at normal motor unit potentials, what we're looking at here is that only a few fibers within about 1 to 2 millimeters are going to record. Honestly, we're not going to, if we put this into the quad, in the distal third of the quad, we're not going to hear or see what's happening 4 feet away or 2 feet away. It's going to be a couple millimeters. So we have to understand that we're only recording and we're only observing what's happening right next to the needle. And other thing to note here, and this is exactly why your patients are going to come in and say, I feel like I've been stuck like a pincushion, is because we're going to do 12 motor unit potentials in each muscle. So that's what you should analyze, is about 12 motor unit potentials. As far as amplitude goes, we're looking at about 300 to 5,000 microvolts, which is a large range. And we could have anywhere from 6 to 7,000 microvolts depending on the individual. Usually type 1 fiber is going to give you around 300 to 1,500. Remember, that's the slower fiber. That is the fiber that's not the fast twitch fiber. Type 2, which is our fast twitch fiber, really, I mean, this is great evidence that it is a fast twitch fiber. It's going to give you a lot more energy. It's going to give you a lot more jolt for your buck, if you will. So we really want to make sure we know those values. Really want to make sure that we understand the difference between those types of tissues. So now looking at what's called a turn. So what a turn is a change in the direction that does not cross the baseline. So kind of take a look at this. This should look a lot like an EKG, right? So what we're looking at here is a very simplistic view of what's happening at a motor unit. Typically, what's going to happen is a motor unit potential is not going to have any turns. It's going to have 0 turns. It's going to go straight up and it's going to go straight down. The duration typically is going to be a function of the synchrony of firing in the individual muscle. So the longer the muscle fires, we should have a longer duration. Now, when I say this, we're looking at milliseconds here. So you're looking at 4 to 12 milliseconds, and that's considered normal. Anything over 12 milliseconds is considered abnormal. Again, this is a slide that I want you to flip over, listen to it, listen to each of these, listen to them a lot. Okay, this is going to be very similar to your first semester PT school when you're listening to heart sounds, but make sure you take the time and you listen to things. So hopefully by this point you've listened to a lot of different EMGs. Hopefully you've listened to them a lot. Hopefully you understand why EMGs sound the way they do and what each of those sounds mean. If you don't understand, go back through it again and listen to them again, please. And the reason being is because I want to make sure that you understand this material. Now, we're going to get into some abnormals here. So we've already been through a few slides of abnormal sounds, but we're going to get into what those sounds mean. So if I have decreased insertional activity, remember I should hear a little something when I put that needle in. What it shows is that the electrical activity is absent or greatly reduced either in amplitude or duration. So it's either not strong enough or it's not long enough. What that indicates is chronic muscle changes such as fatty or fibrotic degeneration. So think about that muscle that's been injured for a long amount of time. Think about that muscle that has decreased innervation to it, either through atrophy or cerebrovascular accident or something happened. So usually if you don't hear anything or you hear reduced sound when you put the needle in, and then that means we're pretty far gone at this point. It means that the prognosis usually is not going to be real good. So when we're looking at something called a fibrillation potential, this is just like atrial fibrillation. Instability of the muscle membrane. Think back to cardiopulmonary class. If someone's an AFib, it means their muscle is kind of fluttering, right? Their atria is fluttering and their atria is not contracting in a synchronous manner because it's unstable. So reasons we would have this are 1, acetylcholine sensitivity. So obviously that's one of your main neurotransmitters. And our decrease in intracellular potassium, because remember that sodium potassium pump has to be just right in order to create a membrane potential. So looking at abnormal activity even deeper, now we're looking at something called a positive sharp wave. What this represents is an unstable membrane fiber. It's very often seen with fibrillation potentials. So again, that instability. But not really a good mechanism or a good pathology is known with this.